Hello and welcome to Triage, timely conversations for healthcare professionals, a podcast created and produced by K&L Gates. Each episode is designed to highlight important developments in health law and analyze the impact on our clients and friends of the firm. We hope you enjoy this podcast.
Hello, everyone, and welcome back to Triage. This is Richard Church. I'm a partner in K&L Gates' healthcare regulatory practice based in Chicago in Research Triangle Park, and one of the hosts of Triage. I'm here with Stephen Bittinger, who's in our Charleston and Washington, D.C. office. And Stephen, I'll let you just say a quick hello and introduction.
Hey, Rich. Thank you very much. Appreciate the opportunity to be here and talk about my practice and some of the interesting things that are going on in the reimbursement and audit world. So thank you for having me.
Very good. Thanks, Stephen. And so for listeners today, today's topic is really looking at the current environment, particularly around audits and reimbursement challenges for all sorts of provider types. For those of you that don't know Stephen or haven't worked with him or seen his work, Stephen is as deep as you could be in this area and handles all sorts of disputes with government payors and private payors related to various audit and reimbursement findings that may be being contested at various levels. So because this is just a continual area of interest to our clients and just a really dynamic area to keep up with, given a lot of changing in the landscape around these issues over the course of the last couple of years, we thought it'd be great for Stephen to just come in and tell us a little bit more about how this practice works, and then more importantly, what the hot topics and things of concern for 2021 are likely to be. So, Stephen, with that, can you give us, it'd be helpful to maybe have just a little bit deeper dive than I just provided on how you work with clients and what your team typically is involved in the reimbursement and audit and integrity space?
Thanks, Rich. Sure. So my practice area, I like to say, is about 1 foot wide and 10 miles deep. I really got into reimbursement dispute work. Boy, I guess it's been a lot of years ago now, and found a niche that I really enjoyed. Truth be told, it's probably because I must confess that I'm a data geek and I really like analytics. So where I really work is in the legal process surrounding disputes within the revenue cycle, not contracts or those type of things, but predominantly what people would think of as the audit space and the law regarding how you're allowed to conduct an audit, how you can defend claims. We work clear down to the claim level in a lot of different payment models, and I've defended a lot of different provider types. So for in-house counsel, really what we are is we're a repository for the very unique reimbursement disputes. You don't need us for in-house counsel, generally doesn't need us for a medical necessity review or any of those issues. But if you get a request from an integrity auditor, fraud, waste, and abuse, or Medicaid, and it's a broader sample, that auditor's there hunting something. And so we understand all the mechanics and processes and law surrounding how to defend audits and recoveries. I work with a really exceptional team here at the firm, and we have actually in-house coding consultants who are some of our industry leaders in a number of arenas that help on research and advising. What I really like to say is that because I work across all the payors all over the country, is that we get to stay on top of the heartbeat of what the reimbursement issues are. And whether that issue arose from CMS or the OIG or one of the commercial payers, we stay current and help people prevent a lot of significant issues because we are so narrowly focused.
And, about what percentage of claims get audited or contested in any given year? I know you've got some statistics on this, and they were really shocking to me.
Yes, so I love math. That'll be a surprise to my high school math teachers, but I love math. So the interesting thing is that to put my work in a broad context, the U.S. spent about $4 trillion last year on healthcare. About $3 trillion of that is payments that went through the reimbursement processes. And I mean, Medicare, Medicaid alone was 1.4 trillion. And across the board, systemically, about 10% of all reimbursement payments are made improperly. And that includes a very small percentage that is fraud, but the most of it is it just didn't meet a coverage criteria, or, there was some element of all the different structure of the validity of the claim that wasn't met. So 10% of the reimbursement in the U.S. last year was $300 billion. And so that's a pretty big bucket of money that wasn't passed correctly. And so that's really the space that I work.
Yeah, the numbers there are staggering, and the 10%, that are potentially contestable is really noteworthy. As we look on the 2020 horizon, what do you think are kind of some of the key issues, healthcare providers ought to be thinking about as they look at where audits may be going this year?
Yeah, certainly. So to put it bluntly, like most healthcare lawyers, I was extraordinarily busy in the past 12 months during the pandemic. And my piece of it was all of the different elements of what makes a service compliant that changed. And so there was a dramatic amount of change to the regulations as far as delivery of services and how they could be provided that all go into determining whether that claim should be covered and paid. Telehealth, obviously, is probably the largest change. But I mean, we had a myriad of them, right? We had cross-state prescribing and waivers of licensure and just so many different elements. And what really occurred from my arena in a data perspective is that providers had a terrible time staying current on the quickly evolving elements of producing a compliant claim. And so I'm already seeing particularly commercial payers who are just taking a lot of audits on telehealth services or elements of telehealth services. There's the traditional ones. I mean, home health, hospice, DME, they are all significant issues, but obviously ventilators within the past 12 months have been a huge scrutiny for DME suppliers. And we're in the process of defending a number of reviews in that arena.
Yeah, very interesting. What about in terms of new strategies and techniques or areas of concern? I know you and I have talked about this really, fascinating problem the VA is about to try to solve with a massive amount of auditing of their own mistakes, essentially. But, what are some of those, unique issues that you see coming, kind of payer specific, that I know your team has been tracking?
Yeah. So, Rich, the VA issue is a great example. The VA issue is what I like to call an evolution of a system. So prior to late 2012, all of the Veteran Affairs outsourced care. So in other words, if a facility couldn't take care of a patient for a specialty treatment or there was an emergency care or something, they went out and were treated by a different provider, and then they would send that claim to the facility, and the facility would process the payment because each of the facilities had their own buckets of money. But then in 2012, the VA consolidated all claims adjudications into a central system. And unfortunately, what happened is the VA failed to do that properly in a number of times and did not load fee schedules in their adjudication system. And that caused providers to get overpaid for 6 years until the OIG investigated and said, where did all the money go? So the VA has actually hired a new significant RAC and is going to be auditing about $35 billion worth of outsourced care over the past 6 years across a broad swath of providers, different hospitals, emergency care, DME suppliers, specialty practice, those type of issues. We don't have too many evolutions of systems very often, but that's a big one. The other real hot issue is the collaboration between government and private payers. It is happening on a level that is different than I have seen in my career. The nerve center of all Auditing and Reimbursement is the Center for Program Integrity, division of CMS, and they're the brain, right? They follow the largest pattern of claims and try and identify issues and trends in the biggest system in the world. And 2 years ago, CPI opened up a collaboration process with some of the largest commercial payers. And so now they are collaborating on what are the hot topics, what are the issues. And so I'm seeing, unlike the traditional 2-year delay, you'd see the government audit an issue and then the commercial payers follow behind when, those results would become public. I'm seeing commercial payers auditing almost in real time on some of the predominant issues. And so, the end result of that collaboration goes clear up to the criminal arena. So like the healthcare fraud takedown with the DOJ in September, they allege it was about $6 billion worth of loss. They did that by collaborating across a number of different states, offices, and payers. And so if the government's getting a lot more sophisticated.
Yeah, fascinating. Another topic that I know I've had a lot of personal experience with, and I know is really key to how these cases often turn out from a more macro level in terms of what the size of a recovery may be, is extrapolation. And I know this is a true data geek topic, so we definitely wanted to cover kind of where things stand on extrapolations and how folks are dealing with those sorts of issues in the current environment.
Yeah, so if there's a hole within this hole, extrapolation is my niche. The interesting thing is that in the integrity arena for the revenue cycle, extrapolation is really a pretty new legal concept. It's still evolving significantly. Most people don't understand is that extrapolation wasn't even used till 1985. I mean, the first time it was used was in 1985, and it was very simple, very elementary, and it has been highly contested and disputed in this arena since then and has evolved a lot. The extrapolation process that auditors have to follow and the setup and as well as the math changed dramatically in 2019 in the Medicare Integrity Manual. And, extrapolation has got a little different place depending on the legal setting. So extrapolation in the false claims litigation arena has been highly contested, and it's really evolving to what I'll call a more neutral arena. A lot of its circuits have come down to the position that, you can't use extrapolation if the only dispute is medical necessity, right? I mean, so if you really have just a clinical dispute between two experts, that's not enough for intentionality to substantiate a claim of fraud. Within, the civil arena, extrapolation has changed a significant amount in the methodology, right? And what I really mean is, so when you take a sample set, what is a sufficient sample set? Right? Have you reviewed enough claims? Is the sample set going to be an accurate reflection of the whole universe of claims that you're going to try to project it against? And even within my super geek arena, I will say that, the providers have been making some headway, right? We have been able to expose a lot of the procedural errors in the extrapolation process. Even as far as the OIG's Office of Audit Services, they use a software system called RATSTAT. And RATSTAT is a computer program that you put in the data and it spits out your extrapolation. So it always does the math right. But the problem is if you put garbage in, you get garbage out. So we recently defended an OIG audit where their sample process was completely wrong. So the result that the software put out was wrong. And so knowing the law surrounding how you have to set up an extrapolation has really started to crystallize, and it helps defend a lot of those allegations.
Super helpful. The amazing thing to me is always, literally tens of millions of dollars typically turn on some small problem and then extrapolating it over such a big data set, those wins are, in my experience, multi-million-dollar wins for every claim you can even pull out of that sample. So that is a great topic to cover. As we wrap up, though, I did want to cover a little bit around, obviously, you've got the you pick at the door. I mean, you kind of know, like, hey, I might need Stephen or good help here. What do you do in a more proactive way? Like, let's say a provider knows that they've got some of those VA claims that are in that period in question. Help me understand how your team might be able to help in the front end to kind of prevent these issues, whether it's in the diligence process or just active self-diligence.
Yeah, great question, Rich. And actually, the majority of my practice is, we do a lot of defensive, but our best defense is offense because unlike a matter where the facts are already concluded, defending an audit, you have an ongoing stream of changing facts, right? So I can many times prevent the big extrapolation by doing corrective action and responding to a smaller probe request. And so, getting a client to understand the importance of not only responding properly to an early sample request, but then understand that they showed up for a reason, right? There's a reason that auditor, asked for those records. You need to go do a root cause analysis, work backwards, and figure out what your reimbursement problem was. And then frequently what we do is we self-audit. I help a ton of clients with self-audit and refund processes or correcting claims. And we do the math and quantification in-house so that, we take the risk of the auditor asserting their big number against you off the table by identifying, fixing, and quantifying the problem and refunding it before you get stuck in an audit that lasts a year or, a Medicare appeal that lasts 5 years. So, I love doing proactive work. We do the same. We take the same tools and mechanics, and we do it a lot in transactional work also. We do a lot of claims due diligence, and that's fun because, hey, you got a target and you want to know, do you have a solid revenue stream, the most important asset that you're buying? And we take a sample of that and say, yes, you do, or you don't. Here are some of those issues. So it's a fun arena to work. It's always a good chess match. So.
Yeah. Very good. Well, Stephen, this has been really helpful and informative. We appreciate you taking the time. And again, not always the best news to hear, hey, I've got an audit, but it's also helpful to hear that there's some ways to hopefully, cut that off at the pass by doing some of that groundwork before you're in an audit. And certainly good to have friends in your camp when it does happen. So thanks so much for your time. Thanks, everyone, for listening in for this week's Triage, and we'll be back in a week with another Triage interview to share with folks.
Thanks again for listening to Triage, timely conversations for healthcare professionals. New episodes are available for download through Apple Podcasts, Google Podcasts, and Spotify. By subscribing to Triage, you will receive timely notifications for each new episode. Also, if you have any topics you would like to hear discussed on Triage, please don't hesitate to email triagesupport@klgates.com. We would love to hear from you.